Here we go. Hello, everyone. Welcome back to Luncheon with the Experts, the Carcinoid Cancer Foundation program brought to you by Tercera Therapeutics. My name is Rain Bennett. I am your host, and I'm a filmmaker. I've been working with CCF for almost 10 years, creating videos like this, and also produced videos to help spread awareness and education about neuroendocrine tumors. So if you're familiar with the program Luncheon with the Experts, you know the drill. Let us know where you're from. Greetings from SoCal. Greetings from Maine. We're seeing some people. We're seeing the numbers come in quickly. Great. So let us know where you are in the world. What's been going on in your lives? Let us know. Let's build our community here today. We'd like to take a moment just to thank Tercera Therapeutics for their support of Luncheon with the Experts. Without them, this wouldn't be possible. And we have a quick disclaimer from them. We want to say that the opinions expressed by the guest presenters, as well as the questions asked by the audience, that you all at home, have not been created or suggested by the sponsors of the program. And CCF does not endorse nor promote any of the views, opinions, or information provided in this presentation. Audience members, again, that is you, should not rely solely on the opinions or information expressed by the guest presenter and should seek guidance and direction from their own medical advisors regarding any treatments or any choices, rather, they make about their health and treatments. So that last line is the main takeaway. It just means we're going to try our best to give you some help, some guidance along your journey today, some information that may help you, but by no means do we know your specific case. So make sure you talk to the home team before you make any decisions. So today our guest is Dr. Alexandra Gangi. How are you, doctor?
I am great. Thank you for having me this morning.
So tell everybody a little bit about where you work, what you do, like how long and in what way do you fit into this neuroendocrine tumor community?
So I am a surgical oncologist at Cedars Sinai Medical Center in Los Angeles. My practice is probably about 40 to 50% neuroendocrine patients who are referred for surgical resection of their gastrointestinal tumors typically. I typically work with more advanced cases, patients who have liver metastases and lymph node metastases and pancreatic primaries. I'm the director of the Gastrointestinal Tumor Program and the Regional Therapies Program, which is probably why I get more of these complex patients that aren't managed out in the community. We have a great multidisciplinary neuroendocrine tumor team here at Cedars, so I'm fortunate to work with all of them, and that is what I do.
So for those watching today, for those of you at home, you may not know this, but Dr. Gangi and I go way, way back. Old friends. When did we meet again?
Yesterday.
Yesterday. We met yesterday. Probably, was it 12 hours ago?
About
24 hours ago, something like that. I was in Los Angeles yesterday. We were hanging out in Beverly Hills doing an interview for another CCF project. And now I'm back in Durham, North Carolina. And we're doing it all over again. So we actually hung out yesterday and talked a little bit about surgery. And that will be obviously one of the topics I'm sure that we have interest about today. But she, for some reason, decided to give me another hour of her time so that we can help you all at home. This is what we do this for. This is why I bounce around the country for you all. Okay, so a few things about the show. If you aren't familiar with Luncheon with the Experts, it's a little bit different than some of the shows we've done before. It's a chance for you to ask any question that you have. It's not super topic driven. Obviously, with Dr. Gangi's background, there are certain areas that she'll really be able to help you with. But she's given us her time, and there are no rules. You can ask her anything. Now, we may not have the time to get to all your questions. So if we don't, just know that you can follow up with Carcinoid Cancer Foundation, either here on their Facebook page. You can direct message them, or you can reach out to them at carcinoid.org and send them an email there. I've mentioned this a couple times in the past few weeks. It really helps me. So if you see a question that comes along in the comments that you also have or you would like the answer to, you can like that question in the comments or love it, and it effectively upvotes it so that when I see it, I know that, hey, there's a demand for this question. It makes it helps me understand that I need to get that one across, because we get a lot of different questions. That also being said, we don't know your specific case, so we can't really answer questions that are very case specific. So try to deliver your questions in a manner where it's still going to give you the guidance and some of the information that you need, but in kind of generic terms, so that we can help give you that guidance. Because if it's too much about your case and Dr. Gangi doesn't know your case, then we can't really help you. As you all know, this this disease is very unique for each patient. And lastly, before we get started, I wanted to say, have you downloaded CCF's free Net Cancer Health Storylines app? The app makes it very easy to record your symptoms, medications, nutritional concerns, moods, and more. So if you haven't, go check that out now. So let's start the show, everybody. Dr. Gangi, she's very excited. So I want to just kind of pick up where we left off yesterday. I think we could have spent more time talking about this. I really appreciated your insights on this disease, but there was something you said that stood out to me when I was just kind of learning a little bit about what led you here, right? And you said that part of the reason why you work or enjoy working with this disease in particular is, like you said, you find it fascinating. That was the word that you used. Tell me a little bit more about that. Like, what is it that intrigues you about this disease, that challenges you about this disease? Like, what exactly do you find fascinating?
The reality is that no two patients are the same. And I think, as you know, carcinoid or neuroendocrine tumors are represented by the zebra stripes. And that's for two reasons. From a medical perspective, when we're in medical school and we're learning things, one of the things they tell us is you have to think of the most common diagnosis. So when you hear hoofbeats, think horses, not zebras. That's part one. The other part of why the zebra print represents neuroendocrine tumors is essentially because no two zebras have the same pattern of stripes. And the reality is that no two patients with neuroendocrine tumors necessarily have the same pattern of disease, the same progression of disease, or any of those similar patterns. And so really you have to review each case individually and decide what treatments may be most beneficial for that particular patient. And I think it's important that you also have to take the patient's wishes into consideration. So it really requires a very multidisciplinary approach, and the patient is certainly part of that team, in my opinion. So from that perspective, clinically, I find it very fascinating. The other piece, my research focuses on evaluating clinical outcomes, specifically surgical outcomes, and how we can improve overall survival and something we refer to as progression-free survival, meaning the duration of time that you either have no symptoms or no evidence of disease progression. So that's been something interesting in developing and understanding where surgery fits essentially in your management plan and how it can lead to both of those things. And then secondarily, how your body's microenvironment is either promoting or preventing these tumors from progressing, trying to understand why you may have, a small bowel neuroendocrine tumor that has a specific mitotic or Ki-67 index. These are things that we look at on pathology to determine the grade of your tumor, and why the lymph nodes may have a very different pattern or expression of those specific things, and your liver metastases can have different expression. Is it something about the liver and the lymph nodes? Is it something about the patient? So these are areas that we try to study, and all of it to me is very interesting.
Awesome. Real quick, I see a hello from Los Angeles, Rain and Dr. Gangi from Lisa Yen, a friend of the foundation. We love Dr. Gangi. So you're already getting some love. Everybody, feel free to shower us both, not just Dr. Gangi. Don't forget about me, please. You mentioned, Dr. Gangi, about, this was during your brief intro today, about the multidisciplinary team and unit that you have there. This is something that comes up a lot in these conversations that we have every week, and the videos that we've done a video on the importance of multidisciplinary teams. Tell me a little bit more about that. Walk me through that. Like, why is it? Because every doctor comes back to this. Why is that something that allows you? How does that allow you to do your job better?
Sure. So, one of the reasons I went into cancer surgery is because I think I recognized early on that I'm not going to be the smartest person in the room. And the more minds are thinking about something, the better decision you may make for a particular patient. And the reality in cancer care is that we all benefit from one another's knowledge. So, I'm not the expert on necessarily every chemotherapeutic agent that exists or every targeted therapy that exists or the effects of nuclear medicine or PRT. I'm familiar with it, but I'm not the expert. I can provide a lot of expertise with respect to the role of surgery and the applicability and what specifically can technically be done. But the reality is that we all depend on each other to get our patients essentially through their treatment and through their diagnosis. So with neuroendocrine tumors, especially because they're so rare, not for us, but they're rare. There's not a huge population of patients who necessarily have them, and I do think we're seeing more, certainly with better diagnostic modalities. You want a team of individuals who have essentially seen similar patients and are very familiar with what options are available, because not infrequently, if patients present with metastatic disease, meaning you have a tumor in your pancreas, for example, and at the time of your diagnosis, you're found to have tumors in other places like your liver. Depending on who you see, if someone's not necessarily familiar with the management of neuroendocrine tumors, you may be told that there's no real treatment for you or no surgical options for you, and that could be derived from the fact that these are people who are used to treating pancreatic adenocarcinoma, which is an entirely different entity, and are just not as familiar with the options that are available. So with neuroendocrine tumors, you want to be somewhere, generally an academic institution or a facility where you have a team of individuals who are dedicated to treating it.
Mhm.
Additionally, we have one of our a tumor board weekly where we discuss patients with new and old diagnoses, where we review imaging, diagnosis, the next step in treatment, and we have opinions from our medical oncologist, our surgeons, our interventional radiologists, our nuclear medicine team. So everyone is trying to think, what is the next best thing for this particular patient, and why, and what can each of us offer, and what would be of the most benefit.
I think that that concept of understanding and seeing the challenge, or just seeing it as like, I'm not necessarily the smartest person in the room, having that little bit of humility is so important, because maybe I'm generalizing here, but I think historically, like, we may have struggled with that. You know what I mean? Like, but hearing, different opinions, different experiences, I think is the way forward when you're dealing with something this complex, this unique, per case to case. I think one thing's safe to say: yesterday, you were probably the smartest person in the room. But I think it's good to approach it from that direction. So it gives me another question. In this community, we talk a lot about being your own best advocate, right? Second opinions, questioning everything. That seems to be the pattern that really helps people forward in this disease. As a doctor, how do you take that? Do you encourage patients to do that? Does it help you do your job more when they're kind of pushing you and questioning some of the things that you're telling them?
Right. I mean, similar to what we're doing on this, podcast or video here. These are my opinions and suggestions in terms of what I think the next best treatment may be for you, and it comes from me and our group. That doesn't mean that it necessarily jives with what specifically you're feeling. I tell patients, when I first meet them, that these are my opinions based on whatever facts and information I could provide to them. I try to explain it to them so that they can actually advocate for themselves and ask the appropriate questions, because I think 70% of my job is probably actually educating the patient about what we're dealing with, so that they can actually understand the rationale behind the treatment. And I tell them, I say, this is something that you're going to be living with for a long time. We're going to be seeing each other. So you need to be really comfortable with me, and you need to believe that I have your best interest in mind.
Okay.
If you do not feel that way with me, I 100% invite you to go see another physician with whom you can develop that rapport and relationship. And I will frequently give them names of other doctors. And I think it benefits me to see what other people may be thinking. Typically, we think the same.
Mm-hmm.
But I think it also benefits the patient to sometimes hear another opinion that was similar to the one we provided them. But absolutely, I think it's great.
Yeah, and I've talked with a lot of doctors in this disease about the strides that have been made in the past 10 years, and I have to think that that's a big part of the reason why. Just that willingness to share information with someone's PCP, or with the patient. Everybody seems to kind of work together in this disease, and I think that that's been helpful. We're starting to get a lot of questions in, so I'm going to go ahead and pivot to that. And then we can chat as the show goes on. So I have a question from Craig that says, when liver metastases are resected, does the liver regenerate? And if so, is the regenerative tissue the same metabolically?
Craig, great question, and one I think I get at least like 3 times a day. Um, so when we think of liver regeneration, it's not like, you hear about a lizard's tail getting cut off and it regrows into a starfish's arm. The liver doesn't regenerate in the same fashion, and that's typically because the vessels and the bile ducts within the liver typically are resected with that area of tumor, depending on what type of surgical treatment you may have had. The liver regenerates much like a muscle would. So if you work out, each of your muscles can hypertrophy, meaning they can grow, each individual cell. So the liver has that regenerative capacity, but it's not going to, if we take out the left side, you're not going to have a whole new left side, but the right side will make up for some of what you've lost. And metabolically, it does behave similarly unless you have an underlying liver condition, something known as non-alcoholic steatohepatitis, or you have cirrhosis from, for a different variety of reasons, or if you've had a lot of chemotherapy that may have required that your liver filter the chemotherapy through, you can have some level of damage to the liver. So in those scenarios, the liver does not regenerate as well and does not function as well as a normal liver would.
Got it. Still staying in that topic of liver metastases, Joe says, what are some of the considerations in deciding which treatment to use with liver mets?
Great question. Joe, the reality is what we look at is the number of liver metastases that you may have, the primary site of origin, what kind of liver metastases are they? Are they from your pancreatic primary? Is it from a lung tumor? Is it from a small bowel primary? What treatments have you had or not had? And that then determines your eligibility for specific types of therapies. So really just all encompassing when you say I have liver metastases from neuroendocrine tumor, without knowing much more than that, really everything is on the table. Surgery could be on the table, PRT could be on the table, interventional radiology procedures like embolization with chemo, just heat, or radiation are on the table, and then systemic therapy or targeted therapies, meaning chemotherapies and things of that variety, are also on the table.
Got it. Thanks, Joe. Next question from Terry. Terry says, what are the parameters for surgery in the mesentery? Is it the size of the tumors? If so, how large? And if it's quantity, how many?
So qualifications for treatment of mesenteric lesions, and I'm assuming, Terry, you're talking about lymph nodes, perhaps? So I'll comment on two things. One, with respect to lymph nodes, really the qualifications for resection of lymph nodes are which vessels they could be involving or surrounding. So the small intestine, it's almost like if you could imagine a curtain. There's a curtain of fat, and within that curtain of fat, you have lymph nodes and you have vessels. So if you have spread to your lymph nodes, depending on where those lymph nodes are in comparison to the vessels within your curtain of fat, and how large they are and how bulky they are, meaning how big, it would determine the possibility of resection. There's a particular vessel within the mesentery or within that curtain of fat that essentially supplies blood flow to your entire small intestine. When the tumor is encasing that vessel in its entirety, it is essentially virtually impossible to get a complete resection, right? Because you would have to, by virtue of trying to clear all of that disease, take those particular vessels, which would then not allow any blood flow to come in or out of your intestine. So you would have no small intestine. So that's usually a limitation, is the location. The size doesn't typically matter. It's more the proximity to the vascular structures. And the number also doesn't really matter. It's all proximity to vessels.
Got it. Thank you. And thank you, Terry, for your question. Everybody, if you're just joining us or you joined us a little bit late today on Luncheon with the Experts, we have Dr. Alexandra Gangi, based out of Cedars Sinai in Beverly Hills. I actually got to spend some time with her yesterday for another CCF project, and we're continuing the conversation today. So if you know somebody that would benefit from today's episode and they may have a question and want to get it in, share this video with them. Let them know the broadcast is happening live. You can also comment their name. You can tag them in the comments section, and that could let them know that this is happening. And hopefully, if they have a question, we can field that today. However, if we don't get to that, or if we don't get to your question, or if you have follow-up questions, just know that this video will be evergreen. It will live here on the Facebook page under the videos tab. And then starting Monday, we redistribute it to YouTube as well for anybody who doesn't have Facebook. So make sure that you pass that along if anyone could benefit from it. But if you know someone that this could help today going on live while we have Dr. Gangi, make sure to share the video and let them know that this is going on. We appreciate you. Okay, next question from Lori. Lori says, just started Folfox. Is that a chemotherapy? Okay. What do you know about the UK study about debulking the liver if the chemo actually works?
Many studies about debulking the liver if the chemo actually works.
So I'm not sure what study, but it just, she said, says the UK study. So I'm not sure if that helps.
Yeah. So Folfox is a chemotherapy, as you asked, Rain, which essentially is 3 different drugs that we frequently use for adenocarcinoma. It's not typically one of the first or second line therapies that we use for neuroendocrine tumors. Not that it's inappropriate, and again, we don't know any case specifics, so I can't comment on that. But the role of debulking surgery in the liver, as I mentioned, if you're a fairly fit candidate, debulking surgery in the liver is dependent on the overall health of your liver, the number of metastases that may need to be removed or burned, and what we feel the overall success would be. So sometimes when patients are responding, we may favor doing a debulking procedure of the liver. Sometimes patients may not respond, let's say, in one of multiple tumors, and we may favor doing a debulking to remove that one particular tumor that is, misbehaving or, treated alternatively. So there's a wide array of options in terms of debulking therapy with or without response to systemic therapy.
She did include that she was grade 3 gastrointestinal primary. I'm not sure if that.
Yeah, so a grade 3 is a bit more aggressive than your typical well-differentiated neuroendocrine tumors with low mitoses and low Ki67 indices. And so sometimes we will treat grade 3 tumors like an actual adenocarcinoma, which is probably why you were started on the Folfox.
Got it. Thank you. I just want to pause for a moment and say that from a few minutes ago, everybody's chiming in saying, we love you too, Rain. So I want to make sure that everybody hears that, because when I pander to the audience, they respond. And I appreciate you all for that. For dealing with me. Let me ask you this question, Dr. Gangi. We talked about why you're fascinated with this disease and the unique challenges that it presents. And I think that's, a big part of why you are fascinated by this disease. What are some of the challenges that are still a struggle to deal with? Obviously there's many answers to that question, but what's one that you really wish you had the answer for today that would make your ability to serve your patients better if you had that kind of that tool? Does that make sense? Yeah. Okay.
Yeah, of course. I mean, I wish I had a crystal ball. I think the challenge for me is knowing that we're making the right decision. And I think that's a challenge I have with my neuroendocrine patients and all other patients. So, frequently there's a lot of discussion, multidisciplinary discussion, other opinions, but we never know how your particular tumor type might behave. And so, the thing that I hate is when I say, we're going to go ahead and remove these tumors in your liver, and we hope that X will happen and we won't see anything for X number of years, right? And then we're wrong. And we're back looking at other alternative types of treatments. And I think that's challenging just because, as much as we know, we still don't know everything. And so there's always the possibility that it's not the perfect right decision. And I don't think we have the ability of knowing that. But what we try to do is make the best decision and educate the patient as to why we think that makes sense so that we can collectively move forward with a treatment plan. But I think, yeah. A magic power. I want a magic power.
Perfect. I asked you a question yesterday that I'd like to ask you again, because I think you did a great job of answering it. You talked about the 3 types of surgeries. I think it was 3, right? Could you do that again for us today on the show and just talk about the different types of surgeries that you can use to treat this?
So I think you're referring to open surgery.
Correct. Laparoscopic. And I think the third, I don't want to do your job for you, but I think the third was robotic.
I mean, more people love you than love me. So
yeah, because I make them say that though.
So really there's 2 big categories. So there's essentially open surgery, big incision, and then there's minimally invasive surgery, which suggests we use smaller incisions and different types of instruments. Minimally invasive surgery involves laparoscopy. which essentially we make small incisions and are able to introduce a camera and instruments with our actual hands without touching anything inside and operate that way. Robotic surgery is done a little bit more remotely, not like we're in another continent, but we're sitting in the room at a different console, and essentially there's a robot that has all of those same abilities to work within your abdomen to do what we're doing, but we're controlling it with our hands. Yes, go ahead. You look like you have a question.
No, yeah, I was just going to say, what ways does I'm interested in the robotic surgery. What ways does that help you do your job better, more efficiently, more effectively?
The robot helps depending on the location in which we're operating. Sometimes the visibility is sometimes a little bit better, and laparoscopic surgery, essentially you have straight instruments. So try to think of, operating with chopsticks. There's no hinges, there's no 360-degree rotation or something like a wrist.
Got it.
With robotic surgery, we have the ability to have a wrist, and so sometimes in tighter spaces like the pelvis or the upper abdomen, it's really important to have that mobility to be able to move. Now, all of these types of surgery are options for management of, small bowel neuroendocrine tumors and some lung neuroendocrine tumors. There's a type of surgery known as VAT surgery and then robotic surgery for the lung. Typically, we advocate for small bowel tumors that, even if you use a minimally invasive approach, because up to 40 to 45% of small bowel tumors can be multifocal, meaning you have more than one tumor in your small bowel and they can be very small. We typically advocate for making a slightly larger incision and actually feeling with your fingers the entire small bowel to make sure you're not entirely resecting the segments of intestine that are involved. With respect to pancreatic tumors, enucleations, removal of pancreatic tumors in the tail of the pancreas or the distal pancreas, and sometimes even Whipple procedures that involve removing part of the stomach, the small intestine, and the head of the pancreas. Those procedures can be done laparoscopically or robotically, but you want to make sure that your surgeon does this on a regular basis and is essentially comfortable performing these procedures.
Got it. Thank you. And I like the image of the chopstick and the wrist. That really helps me understand it with my simple mind. We got a lot of people in attendance now. I see the numbers continuing to grow. So welcome everybody to Luncheon with the Experts with today's guest, Dr. Alexandra Gangi. And we're going to pivot back to some questions from Lisa. Hello from Maryland. What's up, Lisa? What scans, Dr. Gangi, what scans and tests do you rely on for monitoring patients who are completely asymptomatic but have advanced small bowel with mets to the liver and mesentery?
Great question, Lisa. So typically there's CT scans and there's MRIs and then there's gallium scans, and we use them all for different reasons. We typically will follow patients with a CT scan to evaluate essentially the entire abdomen and also the chest. An MRI is certainly more sensitive and specific for evaluation of neuroendocrine tumors that have metastasized to the liver, and that's just because the liver is a solid organ, and so sometimes you're better able to visualize smaller tumors within the liver with an MRI. And then a gallium scan we will do depending on what we may see on those additional scans and what we're trying to delineate specifically. But we will interchangeably use all three depending on what the specific situation calls for.
Got it. Thank you. I'm not sure. I have a question from Karen. I'm not exactly sure I understand it, but she says, does taking supplements to increase your immune system decrease your system from treatment? Do you understand the question there?
I'll try to I might be correct, but she can correct us.
Okay. Thanks, Karen.
Thank you, Karen. I think what you're referring to is, does taking supplements actually weaken your immune system from being able to recover or manage the symptoms from treatments and something of that variety? I don't know if that's correct, but it shouldn't.
Okay.
There are some supplements, and there are patients who, especially here in California, take a variety of things. And the only thing I typically recommend is, if you're getting treatment, make sure that you have discussed it with the treating physician so as to confirm that there's no cross interaction between the two that will make one or the other ineffective or harmful. But short of that, it should not have an effect, but it
Okay.
requires a session.
Got it. Thank you. And Karen, if you do have like a follow-up question to that, hit us back up in the comments. We appreciate you as always. She's a friend of the foundation. Speaking of supplements, from Hendrik, do you know of any research going on about using cannabinoids to treat intestinal nets?
I am not familiar with any research on cannabinoids and intestinal nets. No, Andrew.
That was fast. That was a fast one.
I won't claim to know what I don't know. So
That's good. Yeah. There's that humility again. From Luz, I'm a PNET, but now have tumors on 50% of the liver. Would surgery typically be an option?
Luz, it again depends on the distribution and location and size of the tumors, but surgery certainly could be an option. But alternative treatments can also be options. It depends on your specific, case. Definitely not a no.
Oh, we have a nice message from Lori. It says, loving the patient speak language that Dr. Gangi uses makes these luncheons so helpful. So great job. And if Dr. Gangi is doing a good job, an easy way to at least let me know. She can't see all the emojis. You can send the thumbs up or a little heart emoji and let us know that you're getting some value from the answers. That's a good way for me to visually know. And I will convey it to her and let her know that she's knocking it out of the park. There they come. I see them coming in already. So look at that. It's heart. They love you. So there's a lot of people in the comments that, are asking to consult with you or talk with you. You've conjured up some interest from today's show. So Sarah says, do you do phone consultation? COVID is a scary thing. And Sarah, I hear you on that, especially with what's happening in just the past couple of days. So can you talk a little bit about how you can serve people who may not be in your community, if you're open to that, and how that works?
Yeah, absolutely. I think the positive thing that's come out of COVID is we in the healthcare industry have become more cognizant and aware of how to be more available to patients in that fashion. So yes, we absolutely do phone and video consultations. I do believe there's a link to the Cedars website that would allow you to request a consultation, and then you would go through the routine process. And I'm more than happy to speak, email, whatever it is that would be helpful for you.
Right. She doesn't sleep, guys. Everybody watching at home. She doesn't sleep, so you can reach her at any time of day. She told me that. Yes, sure. Cindy says, are you providing the PRT option at your facility? And if so, what are the pros and cons that you are seeing with it?
We are offering the PRT option at our facility. We were actually one of the sites on the study that ultimately led to FDA approval in the US.
Awesome.
Yeah, it was awesome. It is awesome. What are the pros and cons? And I think this goes back to, each patient responds differently, and each case is a little bit different. So overall, a majority of our patients have had good responses. Some with, almost complete, and some with stability of disease. It depends on the number of treatments, and overall, if we look at kind of the duration of time they were treated. Something that does come up is something known as myelodysplastic syndrome, or like blood-borne disease secondary to PRT. We at our institution have not had any patients thus far that have developed that, but we do know from data from Europe, which is where all this started, that there were some patients who developed myelodysplastic syndromes or blood-borne disorders secondary to treatment. But overall outcomes are good.
Got it. Thank you. All right. We have a question from Bernard, our friend of the foundation, all the way from Kenya, who joins us every week. What's up, Bernard? Good to see you, my friend. How useful is 5-HIAA for diagnosing NETs?
So 5-HIAA is essentially a byproduct of hormone secretion from neuroendocrine tumors. It is something that we used to use fairly frequently, probably about as little as 5-7 years ago, I would say.
Mm-hmm.
And you can check it in the serum, and you can actually also check it in the blood. And we used to typically have you do a 24-hour urine analysis where you went and collected your urine for an entire day and brought it back to the lab, and they would look for these 5-HIAA levels. And if they were elevated, then we would say, oh well, there's a suspicion that you have a neuroendocrine tumor. It wasn't definitively diagnostic. The byproducts of the particular hormones of the 5-HIA could be elevated secondary to different things that you've eaten, like walnuts, bananas, things that are high in tryptophan. So there's a very specific diet that you have to follow. Patients who have some underlying chronic kidney disease can have elevated levels of 5-HIA. So it's fairly non-specific. So we typically don't use it as a diagnostic modality anymore. And most recently, we've looked at something else known as chromogranin for the same reason, because that was another blood test that we were using to evaluate and diagnose neuroendocrine tumors. And we've also we're stepping away from doing that. Where both of those things may help is depending on the degree of disease that you have or what you present with. We can sometimes use those markers, again, if used correctly and we follow all the dietary limitations and everything you're supposed to do before getting these checked, to see how you may be responding. So, if your tumors are responding, you may see a gradual decline in some of those markers that could be indicative of a response. But we don't use them as the only diagnostic modality.
Got it. Karen asks, what are your feelings on blood tests like advanced micronutrient, hormone levels, copper and zinc?
I'm going to say the same answer I gave for cannabinoids and small bowel neuroendocrine tumors. I don't know of any data that necessarily supports doing that, but it's not my area of expertise by any stretch.
Got it. And Pat Murphy, friend of the foundation, says, I love it when doctors admit what they don't know.
Thank you, Pat.
No, I mean, honestly, like we can laugh about that, but I think that's so true. And I think that's something that has changed in medical treatment over the decades, is that people understand, that there's a lot of things to consider with, especially with a disease like this. Moving right along, question from Allie. My question is in regards to lanreotide injections. I was told it has warp speed my menopause, and now my body joints are failing. Is this normal? Have you ever heard of this?
I have heard of it, and it can absolutely happen, unfortunately. And again, everybody responds a little bit differently, but certainly it's something that we discuss when talking about the use of lanreotide or octreotide, or what we call somatostatin analogs to patients in terms of the risks.
Got it. Thank you. Next question from Top Fan Eva. What's up, Eva? Do you use the pancreasstatin test as more of a diagnostic tool, or do you order this test as part of a regular maintenance regimen?
I personally do not order it as a routine regimen. I may in a particular patient if we find that there's elevation in that hormone, and again we're following the disease. There's another marker known as pancreatic polypeptide, and that typically is a little bit more useful, and I use that more frequently in my practice.
Got it. From Terry. Terry says, are tumors without receptors less worrisome, don't light up in gallium scan, but show up in CT and MRI?
Terry, great question. I think the short answer is no. The only thing that having a tumor without a receptor really indicates is that it would not be sensitive to somatostatin analog therapy or anything that would target your somatostatin receptors like PRT. So it's not that it behaves better or worse. It just may not behave in a way that would be amenable to certain types of treatment.
Got it. Lynn asks, is alpha PRT offered often? And if so, why and where? And can you?
Yeah, no, I'm not familiar with alpha PRT specifically.
But that is a thing, right?
Yes.
Okay. That's relatively new?
I believe so.
Okay. Lisa had a question earlier. She has a follow-up. She says the last, I don't know if I have enough information here, Lisa, but it says the last part of my question was unanswered. Apologies for that. In regards to using liver values to monitor liver health, is there enough there for you to go off of?
Are you looking at liver enzymes specifically and how that, yeah, so we do use something known as a liver function panel.
Okay.
And there's a slew of different things that are within that panel, like a bilirubin, something known as an AST and an ALT. And that essentially tells us how healthy your liver is. So that is something that we will follow in patients who have liver disease, who may have had liver-directed therapy, who have had liver surgery. And that could be indicative of disease progression or damage to the liver secondary to different treatments.
Got it. Thank you. We've got a couple questions coming in from Lisa Yen from LACNets. Hello, Lisa, again. And she says, here are some questions that often come up in support groups, not just hers. When might you perform surgery with peritoneal disease?
Lisa, great question. So as a surgeon, I perform surgery for peritoneal disease fairly frequently if we feel that we can debulk a majority of the disease. So again, it all depends on the pattern of disease and spread. I know Rod Pommier, who you may have heard of, he's a big advocate for cytoreductive surgery for neuroendocrine tumors, as is Jim Howe. So a majority of the surgeons who treat neuroendocrine tumors do feel that by decreasing the burden of disease in the abdomen, there is a benefit for the patient. So it's not infrequent that patients with what we call peritoneal carcinomatosis, meaning disease within the peritoneal cavity, which is your entire abdomen, would still be eligible for surgical resection or removal of these tumors, dependent on if we feel we can do it with 90+% success.
Awesome. Shout out to Doctors Pommier and Hal, both friends of the foundation and have been on the show. Well, Dr. Pommier will be on the show, but I've spent some time with him already. In fact, he will be included in the video on surgery that I worked with Dr. Gangi on yesterday. So for those that haven't seen any of that series, we've got about six or seven of those out now. And I think we're doing 9 total that we've been releasing throughout the year. We've covered PRT, we've covered multidisciplinary teams, net guidelines, nets in children, a lot of different aspects about this disease. And you can find those videos also on the videos tab here on the Facebook page or the Carcinoid Cancer Foundation YouTube channel. So if you want a little deeper dive into some of these specific aspects, lung nets, we have a video coming out on clinical trials. Go check out those videos as well, but definitely want to say hey to Pommier and Dr. Hal. Also from Lisa, when you remove primary nets only versus removing the metastases to the liver, when do you remove primary nets only versus removing mets to liver at the same time?
So this is an ongoing topic of debate.
Good. Controversy.
There is, and it again depends on your primary tumor. For small bowel neuroendocrine tumors, there's currently a trial underway in France evaluating the utility of removing the small bowel primary in the setting of unresectable or unremovable or untreatable liver disease, surgically untreatable liver disease. And there's been a few retrospective studies, including one that we published recently, where it looks like there is a benefit for patients in removing the primary disease within the small intestine in the setting of surgically unresectable liver disease. And part of that reason could be because ultimately, if the small bowel tumors continue to grow, you can have certain catastrophic events could occur. You can suffer from bowel obstructions or bowel blockages because the tumors can essentially block the passage of food and enzymes and materials that your intestines are making from passing through. That can sometimes cause a perforation because just like a pipe, there's only so much pressure that your intestine can hold before it bursts. Also, I think we discussed a little bit earlier that the lymph nodes kind of sit in that curtain and can encompass the different vessels. And so if those continue to grow, sometimes they can cause essentially occlusion or blockage of those vessels and prevent blood flow in and out of certain parts of the intestine. And you can get severe abdominal pain and again, potential complications there. So those are kind of the thoughts behind why we should consider doing it. One other consideration is that in removing the primary, are you actually slowing the growth and spread of additional disease by having removed that disease focus? We certainly don't have an answer to that, but it is an excellent question in an area of ongoing discussion.
At what point, if any, would you revisit surgery as an option again if you've already performed surgery in someone's treatment? Can you revisit that as an option? If so, when and why?
You can always revisit surgery, in my opinion. But again, it depends on why are we revisiting surgery? Is it because there was disease that was left behind? Is there new tumors in locations that didn't exist before? Are they tumors that are not manageable by different treatment modalities? Like, are you not somatostatin receptor positive? Is it not an option for you to have PRT? Do we not have good chemotherapies available? So frequently I'll see patients who were, referred after having had emergency surgery. And so they've had incomplete resections with a new diagnosis of neuroendocrine tumors. So in those settings, we like to go back and make sure that we've done an appropriate all-encompassing resection. That's not uncommon. In patients who have previously had surgeries for their primary tumor, who many years later may come back with new metastatic disease that's resectable, we may revisit surgery. Sometimes there's complications from surgery that need to be corrected. You revisit surgery.
Yeah.
So yeah, it depends entirely on the scenario.
What about the flip side to that question? When, in what situations would surgery like not be an option?
Sure. So I think one, patient preference. I've had patients who absolutely don't want to have surgery, either because they've seen someone go through it, or they've personally had a bad experience, or they've cared for someone who's had a bad experience, and so that's always that's one possibility. Two, depending on your overall health. So, if you have severe heart disease or lung disease that would preclude you from safely undergoing anesthesia, if you wouldn't be able to tolerate that, then obviously it's a very high risk for you to undergo surgery. And so you may not be a candidate that way. Sometimes we have patients who develop carcinoid heart disease who aren't candidates for surgery. And so sometimes what we have to do is manage their heart disease initially, and they can get a valve replacement or things of that variety and then become eligible for surgery. So those are the scenarios in which you would not be a surgical candidate if we feel that your overall health is too poor to actually tolerate successfully going through the procedure. And then secondary to that, obviously, we want to make sure that surgery would be of some benefit to you. So in certain scenarios, if we're going in, for example, for liver metastases, and I know that I'm only going to be able to treat 50% of the liver metastases, we have good data that there's really no benefit in terms of symptom control or survival benefit if I can't treat at least 70% or so of that disease. So there are specific kind of considerations depending on what we're looking at.
Okay, so everybody, we have about 15 minutes left with Dr. Gangi. So if you do have questions, go ahead and get them in now. And just a reminder, if we don't get to your question or if you have follow-up questions, you can reach out to us here on the Facebook page. You can send a direct message or at carcinoid.org. Still have questions, great questions coming in from Lisa. Lisa, I appreciate you and you're delivering them so well. Nice, succinct, simple questions. What, if anything, can be done to prevent adhesions following surgery?
$1 million question, and if you figure it out, certainly let us know. Great question, Lisa. There really isn't much. We do think that using minimally invasive approaches can decrease to some degree the number of adhesions that you may develop, but the reality is we haven't really seen that come to fruition. The thought behind it is because we may not necessarily be handling or manipulating as much of the abdominal cavity, you're less likely to develop adhesions in areas where we haven't worked. But short of that, there's not a tremendous amount. There is a type of anti-adhesive called Seprafilm that we sometimes use, and we've seen that work and not work. And so again, no guarantee in order to prevent adhesions. There's some patients who just form more adhesions than others, and that's the unfortunate reality.
When do you rescan following surgery to reassess?
Depending on tumor type, what we've done, somewhere typically between 3 and 6 months.
And for how long?
For years. I mean, again, it depends on what specifically we're looking at, but usually it's 3 to 6 months for the first 2 years, and depending on patterns of progression or lack thereof, we may either shorten those intervals or make them longer.
Got it. If patients experience chronic partial bowel obstruction type symptoms, how long might you watch and wait versus move forward with surgery?
I typically advocate moving forward with surgery because clearly your body is telling you that things are not working appropriately. But I think a lot of that decision comes down to what we think the surgery would be able to achieve and the patient's comfort and understanding of what specifically the surgery is going to do. I certainly think the sooner the better, just because, as we mentioned, the possibility of obstruction and perforation and all of those things. And if you're already having symptoms, my concern is always, because we don't have a crystal ball and we don't know what's going to happen in the immediate future, if we're having symptoms, then certainly sooner is better.
Got it. Thank you. And thank you a lot, Lisa. That was very helpful, and hopefully helps some of the people, members of your support group as well. Question from Jason. Jason says, I'm one of those unlucky ones that have the tumor wrapped around the vessels and arteries feeding my small intestines, and surgery is not an option. My question is this: does this cause any issues with the actual vessels/arteries themselves? E.g., any possibilities of eventually slowing down or cutting off blood flow or anything like that as the tumor continues to grow?
Jason, great question. So it is possible that it's able to do that, but typically, remember, these tumors are so slow growing, and the human body is really quite fascinating in that when that does happen, you essentially form collaterals, meaning different pathways and different vessels that don't depend on where specifically that tumor may be encroaching on the vessels, so as to still supply blood flow to the remainder of your intestine. So it can happen. How often do we see it? Fairly infrequently, which is probably why we don't take everyone to surgery, immediately with the risk of potential imminent demise. Frequently, what we will see is patients who have the type of scenario that you're describing have a very rich network of collateral blood flow to the intestines, just because the body is capable of adjusting appropriately.
Got it. Thank you. Karen asks, does this cancer cause high or low heart rates? I know when you have carcinoid syndrome, heart valve issues arise.
Yeah, so it certainly can. Carcinoid syndrome can be associated with, elevated heart rates, sometimes wheezing, flushing, diarrhea, things of that variety. There's something known as carcinoid crisis that can arise from an overwhelming release of hormones. This can happen spontaneously, although very rarely. It's typically described in the setting of having some type of procedure which involves manipulation of the tumors, meaning either handling at the time of surgery or biopsy, or even PRT or different types of treatments. In those settings, you can have all sorts of responses, including a decrease in your heart rate or an increase in your heart rate drops, or elevations in your blood pressure, and again, respiratory compromise. So yes.
How do you monitor for or control carcinoid syndrome during surgeries and during hospitalizations in general?
Right. So again, it depends on whether you're on a somatostatin analog, receiving monthly injections or not, what specifically your symptoms are. If a patient is typically asymptomatic, then there's a lower concern for the development of carcinoid syndrome or carcinoid crisis intraoperatively. However, for me, for example, I have a specific team of anesthesiologists with whom I work. Sometimes we do give octreotide in the operating room, although the most recent data does not suggest that the changes that we're seeing in basically the patient's hemodynamics or their blood pressure or heart rate are necessarily related to an overwhelming release of hormone. And that was a study that was done out of Oregon. So frequently we will use what we would use in a normal patient who had compromise of their heart function or heart rate or things of that variety to treat it. But again, it's important to have the right people in the OR and make sure that there's clear communication in terms of what we're doing, what type of symptoms the patients have and what could arise. And I certainly always tell my anesthesiologist, if at any point there's something that's changing as I'm operating, you have to let me know to stop so that we can assess and address the problem before we continue. So that's how we manage it.
Okay, everybody, we just have a few more minutes left and a few more questions, so we're going to try to churn through these while we still have Dr. Gangi. Lynn says, if PNETs with metastasis to the liver is diagnosed in a younger person, such as in their 30s, does this make it more critical for siblings and other family members to get genetic counseling?
Great question. So PNETs encompass about 5 to 10% of all types of pancreatic cancers. I'm including adenocarcinoma. Now, a subset of patients with pancreatic neuroendocrine tumors or duodenal neuroendocrine tumors can have a genetic predisposition syndrome. So depending on the tumor type, and the particular family history that could certainly play a role in requiring genetic testing. For specific cancer types, we advocate for genetic testing in patients who are younger than 40 who are diagnosed with cancers. But again, it depends on what type of PNET you may have, but it certainly could be related to a genetic predisposition in that family.
Got it. Thank you, Lynn. And a final question from Lisa, actually. It says, when does the ileocecal valve need to be removed? And do patients have a say in that?
Great question. So the ileocecal valve is essentially where your small intestine connects to your large intestine. It's essentially right at that corner. And what the valve is supposed to do is prevent stool in the large intestine, which is still quite liquidy because it's literally just made it out of your small intestine, from refluxing back into the small intestine. Now, there are a subset of patients who have an incompetent ileocecal valve, or that valve doesn't work, and you wouldn't know it. So the ileocecal valve is a little bit less important than we may think it is. When do we resect it? It depends on the location of the tumor. So as I mentioned, the vessels determine ultimately how much intestine we may need to take. And there is a vessel known as the ileocolic vessel, or the ileocolic artery and vein, that goes directly to that site of connection between the ileum and the right colon. So in the setting of having a tumor in the distal ileum, or the initial part of the colon, or the very end of the ileum, frequently we want to take that segment of intestine and the surrounding mesentery, or that fat curtain that has the lymph nodes. By doing that, we have to take that particular vessel, and therefore the ileocecal valve will come out. So it depends on where your tumor is and what we're dealing with.
Are there any things that are coming down the pipeline in the near future that you know about or are excited about that will help you do your job better in terms of surgery?
Yeah, so I think I think there's a lot of things in the pipeline. I think given the advances that we have with systemic therapies and targeted therapies and PRT and things of that variety, just determining what our treatment approach should be. In patients with metastatic tumors, should we do PRT first? Is that going to allow for maximal shrinkage? Should that be followed by surgery? Vice versa, where does treatment fall into the line? So I think now that we have more options, just determining what treatment algorithms we should follow for patients, that's an area of interest. Personalized medicine is something we hear more and more about, and next generation sequencing and subtyping of tumors for specific tumor types. That has been a tremendous benefit because patients become eligible for different types of therapies based on their specific tumor. There is some research being done on organoids, so development of tumor tissue from patient-specific tumors outside of the body that can then be tested with different types of medications to see if they'll be responsive to that particular tumor type. So development of all of these things are in the pipeline and are certainly interesting. And all of us who treat neuroendocrine tumors are excited to work with our patients to see how we can achieve the best outcome by using all of these modalities.
What advice would you give to a new patient on what they could do to also help achieve the best outcome?
So I would say, most importantly, educate yourself, but do it in a way. There's innumerable foundations like the Carcinoid Cancer Foundation, LACNets, and all of these resources available for you with patients who are very aware and very involved and have gone through the process, who are so excited to share with you what their journey has been and what they've learned. The utilization of those resources, I think, is invaluable. Recognize that this is a new diagnosis and it may be a new way of life. I tell my patients, this is not a sprint, this is a marathon. We're going to have to revisit different things at different parts of your treatment. Everyone is certainly striving to do the best that we possibly can for you. And I think, find a team of experts with whom you feel comfortable. The reality is that, some patients may not have access based on, geography, where specifically they're located, to have a neuroendocrine team available to them. But very, very frequently we'll see patients from, different states or different areas in California who will consult with us, and then we can work with their local physicians in order to make sure that we're doing what we can in order for this patient to achieve the best possible outcome. So I think, educating yourself, remaining hopeful, and, getting additional opinions should you feel like you're not getting the whole story.
Yeah. And I think that, I mean, that is a big part of the mission that we have here at the foundation and the work that we do, and why I'm so fulfilled by seeing the community that we've built here that happens within the comments and the overall net community. It just comes back to continuing to share this information, share our stories with other people and our experiences, so that more people can be aware of this, doctors, patients, the general public as well. And so I hope that we can continue the same increase in treatment of this disease that we've seen over the past 10 years. That would be really awesome. And I think all of us that are a part of this community, what we can continue to do is continue to spread this awareness and education about it. So that's it for the show today, everybody. We have reached our time. So Dr. Gangi, thank you so much. Again, same time tomorrow. Are we doing a podcast tomorrow, or want to go for the streak?
Let's do it. Thank you so much for the opportunity and the invitation. It was a pleasure.
Yeah, absolutely. And I have to say, like, your office looks super clean back there. Most doctors, it's a mess, but it looks so clean. I don't know how you pull that off.
Right.
Thank you again, sincerely, for joining us. It was a pleasure. And thank you to you all at home. Of course, we hope this program helped you and helped answer some of your questions. And if not, or if you have follow-up questions, of course, always reach out to Carcinoid Cancer Foundation at carcinoid.org, or again, here on the Facebook page where you are, you can send them a private message if you have any questions. And thanks again to our presenting sponsor, Tercera Therapeutics. Without them, this program wouldn't be possible. And again, as always, my name is Rain Bennett, your host. Thank you for watching. Please join us next week on Luncheon with the Experts. Stay safe, stay healthy, everybody.